My name is Joel White, by the way. I'm the executive director. We're a coalition of about 60 different organizations, primarily patient, payers, and provider groups that came together to support health IT adoption and use to improve care quality and lower healthcare costs. So we think that the two rules combined are a good step forward from the baseline, from the current structure, where there are no Medicare or Medicaid incentives to adopt health information technology. So it is actually encouraging people in a structured way to adopt health IT to better quality and reduce costs. It is a step back from the proposed rule, and I'll go into some of those changes in a little bit. But I think ONC did a good job, CMS did a good job, and like I said, we're going to have to implement now, we're going to have to execute, we're going to have to get the job done because we believe that health IT holds significant promise to improve care quality and reduce costs. And we're also looking forward to working with our provider partners to get some more information out there and to assist them in becoming meaningful users now that the bar has been lowered a little bit and made a little more flexible for them to adopt and use. So Meredith talked a little bit about what the rules mean. Basically, if you're an eligible provider, basically a doctor, or hospital, and you participate in this voluntary program, and you meet these meaningful use requirements, you get incentives out of the Medicare program or the Medicaid program or both. And what we're really talking about, what you're seeing reported in the press, I think, is what are those requirements? What do I have to do in order to be able to meet these things? And that's where some of the disagreements are surrounding. And so let me get into a little bit of those requirements. There's a core set that people have to adopt in order to meet the meaningful use requirements and get those incentive payments. And then there's a menu of other things that they can choose from in order to meet 5 of 10 options. It's kind of like ordering from a Chinese menu. You get fried rice or an egg roll, based on your preference. Like I said, it's okay to laugh. So I'll just focus on a few of the core set. The core set is 15 different standards, okay, that the eligible professionals and hospitals would have to do. These include things like recording a patient's vital signs and updating their chart. Doing things like recording a patient's demographics, maintaining an active medication list. And when you go to the healthitnow.org website, you'll be able to see a list of all these things. But there's a lot of things that you probably hear a buzz about that people are paying a little more attention to. One of the core requirements is the electronic health record has to allow you to e-prescribe. Okay? The standard in the proposed rule was at least 75% of the time. The standard in the final rule is at least 40% of the time. So make it a little bit easier for some of those prescriptions. There's another core requirement called computerized physician order entry. This is where you actually electronically enter in orders for things like imaging, lab tests, referrals, medication orders. The proposed rule said that eligible providers would have to do that 10% of the time. The final rule changes what that applies to. It's only for medication orders. So not imaging, not referrals, not things like that. For 30% of the patients with at least one medication order. So it narrows the population and who it applies to. There's a lot of other things, like I said, we can list these out. Perhaps two more I'll highlight. The first is called clinical decision support. Clinical decision support, basically, if you're a physician and you're ordering, say, Coumadin, which is a blood thinning product for a stroke patient, and the patient is on, say, Lipitor, which is a blood pressure medication. Clinical decision support will do a pop-up and they'll say, do you really want to do this? This could kill the patient. Sounds like a neat function to have. Well, my doctor had that. The proposed rule said you have to have 5 of these special rules. 5 different instances where they say Coumadin shouldn't be used with Lipitor, or this patient's already had MRI, do you really want to order another MRI, things like that. The final rule says you only have to do one, but you have to track it. You have to track compliance with that clinical decision support. And then the last one I'll talk about a little bit is reporting on clinical quality measures. HHS started out with a big list. They were all National Quality Forum endorsed. They scaled back that list fairly significantly to a much smaller list. And for 2011, clinicians are going to have to report on those quality measures via an attestation. Just basically raise my hand and say, yeah, did that. And then by 2012, we'll have to submit the clinical quality measures electronically, which is good because we have good data on clinical quality measures. We can start to judge how people do, how they perform, maybe what's happening in the population to be able to understand what interventions or treatments maybe are working very well. So again, another effort was scaled back, but still going forward in a way that ultimately is going to help improve quality and reduce costs. So overall, this is a step forward from where we were at, which is basically zero, current baseline. It was a step back from the proposed rule. But all in all, we need to move forward. And in Congress here, you're going to be hearing a lot from providers, I think, a lot from other groups. But I think the important thing now is, now that it's final, we all need to work together to get some good information out there and ensure that folks become meaningful users of health IT, because it really can help improve quality and lower costs. Thanks.
Very good. Thank you.